Well, thank you. Welcome everyone to this virtual Grand Rounds. My name is Luis Querol. I am a neurologist from Barcelona, Spain, and I am going to talk about innovations in IG treatments in CIDP in this activity organized by CME Outfitters with us, supported by an educational grant from Takeda Pharmaceuticals. So one thing that is important is we are going to discuss about the CIDP in general. We are going to talk about some drugs and therapies that are approved and some others that are not yet. And I will inform you about this off-label use or investigational use of some of the drugs that we are going to discuss. So you are aware that these are not necessarily all of them approved therapies. So, as I said, I am Luis Querol. I am coordinator of the Neuromuscular Diseases Unit at Hospital Sant Pau and an associate professor in neurology in Autonomous University of Barcelona in Spain. But this is an activity that we have prepared together with Professor Richard Lewis from Cedars-Sinai, and both of us have built the content and organized this activity. And these are our disclosures, both my disclosures and Professor Lewis' disclosures, and also the disclosures of the team that has helped us develop this activity. So going to the point, we have three learning objectives. The first one is to incorporate the use of the recommendations of the guidelines of CIDP to facilitate an early and accurate diagnosis of CIDP, which is something that it's not so easy or not often follows the guidelines that are published. The second learning objective is to describe and learn to utilize real-world strategies to implement novel immunoglobulin targeted therapies. We are going to talk about not only immunoglobulins, but also about other therapies. But one important learning objective is so the care of CIDP patients needs to be implemented in a collaborative way to improve not only the care in general, but also the detection of complications, making the management more efficient, etc. So starting with the first learning objective, which is enhancing CIDP diagnosis, particularly focusing on the use of the guidelines and the tools that the guidelines recommend to diagnose accurately CIDP. Starting with an introduction, CIDP is a rare disease. The prevalence varies a lot depending on the studies we look at, but usually it ranges, for example, in European countries, around 3 per 100K inhabitants in the prevalence. It's a disease that presents with weakness, which usually is proximal and distal in the four limbs, sensory symptoms, which can be deficit or paresthesia, and a reflection. And then, depending on the variants that we will see later, there are different patterns of appearance and different patterns of progression. Most of the CIDP patients present with either a chronic progressive or a chronic relapsing phenotype, but some of them may be monophasic even. And in fact, there's a substantial proportion of patients, around 20% of them, that enter into remission. And of course, the relapses or flare-ups are disabling and leave the patient with discomfort and with disability that not necessarily enters always into remission, even with optimal treatment. So altogether, it's a disease that is associated with significant physical, social, and economic burden. One important thing about diagnosis in CIDP is that diagnosis in CIDP is a little bit complicated, and it's complicated, and we will see, due to the nature of the disease and also due to the nature of the guidelines of the disease, which are, of course, interrelated. But two phenomena happen, and that may seem paradoxal to some extent. So, on the one hand, it's well described that it's delayed diagnosis. On average, depending again on the environment we are, it takes from 1 to 2 years to diagnose CIDP from symptom onset. And of course, the consequences is there's a delay start of the treatment, and this, of course, may associate with more axonal damage in the end and more disability that is not reversible. And then a phenomenon that has been very problematic lately, and particularly for clinical research, is misdiagnosis. So CIDP is not a disease; it's a syndrome. It's let's say an aggregation of different specific disorders, and the criteria are pretty broad. And this breadth of the criteria makes them incorporate sometimes neuropathies that are not necessarily immune in origin and that are treated differently. The consequences of having this misdiagnosis, of course, is unnecessary interventions both in the diagnostic part and also in the treatment part that are unnecessary. And this over-treatment and overuse of technologies, again, is subject to complications and to problems to patients. So both of them harm the patients. How this develops in the end or leads towards worse outcomes is not very well understood, but it's logical to think that if we are not diagnosing the patients promptly, or we are failing to diagnose CIDP or assigning CIDP diagnosis to other things, of course, this will not be good for the patients that are suffering this delayed diagnosis or misdiagnosis. And of course, this has impacts not only in the patient outcomes, but also in the healthcare at large, including the costs. When this slide has become a little bit, let's say, very illustrative of the problem. So this is taken from Jeffrey Allen and Richard Lewis' paper around 10 years ago, which describes that around 50% of the patients that are diagnosed with CIDP and treated as CIDP patients do not have CIDP when are reassessed by an expert center. And you see here the amount of different disorders that can mimic CIDP or can be misdiagnosed with CIDP. The most frequent you see here, and this is logical, is diabetic polyneuropathies, but also some other neuropathies like idiopathic chronic axonal neuropathies, hereditary neuropathies, MMN, which is relatively similar in some aspects to CIDP, and some others that are not so straightforward, like fibromyalgia or ALS, but that, as you see here, are also part of this misdiagnosis that happens frequently in CIDP. So due to that, and despite we had criteria in place that were the EFNS, the European Federation of Neurological Societies, and PNS, Peripheral Nerve Society criteria, we had those criteria in place when this paper by Jeff Allen and Richard Lewis was published. Despite the criteria, we had this problem. So when in 2021, there was the idea to revise the criteria by the European Academy of Neurology and the PNS again, so the focus was placed in try to decrease the misdiagnosis, to try to make diagnosis more accurate and less, maybe losing some sensitivity in the criteria, but trying to gain more specificity. And there were some very, let's say, broad changes, which are here described. So, for example, the first one was more in the nomenclature. So the typical CIDP and the atypical CIDP were changed to typical and CIDP variants. Also to, let's say, not focus on stigmatizing a little bit the ones that were atypical. In the electrodiagnostic part, there were 3 levels of certainty for the diagnostic: definite, probable, and possible CIDP, but the difference between the probable and the possible was minor. So to simplify the guidelines, only possible and CIDP were the diagnostic categories. Then the supportive criteria were essentially the same, but they were more precisely described in what was required to meet the supportive criteria in order to use it to increase the level of certainty for the diagnosis. And finally, altogether, this led to the creation of only two categories for diagnostic certainty, which was CIDP and possible CIDP contrary to what happened in the previous guidelines, in which we had 3 different categories. So first thing that we did in these new guidelines of CIDP was to describe well what it meant to have each of the variants, or at least better than it was in the previous guidelines. Because before there was a description that there were different types of CIDP, but there was not a clear description of what it meant to have each of the variants. So typical CIDP is pretty straightforward. It's the same as it was in the previous guidelines. You have to have, the patient has to have a progressive or relapsing symmetric proximal and distal weakness with sensory loss in at least 2 limbs. And then these symptoms need to develop over 8 weeks, which is something that is common to all the variants, and absent or reduced tendon reflexes in all limbs, usually most prominently in the legs. But then we come to the disorders or the variants that are more frequently misdiagnosed. The most frequently misdiagnosed is the distal CIDP. And distal CIDP now is described, as you see here, as distal sensory loss and muscle weakness, predominantly in the lower limbs. And you will see later that also the electrodiagnostic criteria are specific for each of the variants. Multifocal CIDP is sensory loss and muscle weakness in a multifocal pattern, so it has to involve at least 2 limbs. And usually it's upper limb predominant, but it's not restricted to upper limbs, or not necessarily restricted to upper limbs. Then focal CIDP, we need to have a disease, so weakness and sensory loss in only 1 limb, but in more than in 1 nerve. And then motor and sensory CIDP are pure variants that behave in a symmetric way, the same as the typical variant, but are only presenting with motor or sensory symptoms, or predominantly motor or predominantly sensory symptoms. One important thing we have in here is that sensory CIDP can only be possible CIDP. So there's no way to upgrade it to full definite CIDP, because it's always another variant that is frequently misdiagnosed. The cornerstone of the criteria is the clinical presentation. And without a clinical presentation, we cannot apply, or we shouldn't be let's say, we should be cautious applying the electrodiagnostic studies. So we first need a clinical criteria and then the electrodiagnostic studies, which are usually nerve conduction studies, which need to be done. It's mandatory, let's say, to reach a CIDP diagnosis, and they contain different criteria that we are not going to detail, but usually aimed to find what we would call demyelinating features in the nerves. And then we have supportive studies, which include imaging like ultrasound and MRI, which are used to detect enlarging of the nerves or the roots. And depending on the MRI, on the technique we are using, we will use different parameters, but usually it's an increase in the cross-sectional area. Then we have the lumbar spinal, the cerebrospinal fluid analysis, in which we would expect to see an increased protein content with no cells or fewer than 10 cells. But if this happens, we have to bear in mind that in patients older than 50, the cutoff of 0.6 grams per liter is recommended, because otherwise lower thresholds may determine maybe much less specific. The nerve biopsy is rarely needed, but it's important in very specific cases. So it's almost never necessary, but it's necessary in patients in which we either are convinced that the patient has a CIDP, but we are unable to reach the necessary certainty to start treatment, or at least or also in those patients that do fulfill criteria of CIDP, and we think that they may have another disease, like, for example, amyloidosis, which is a disease that it's often misdiagnosed with CIDP as well. And then we have the serological testing, and this includes antibodies that we will discuss later, but also, very important, everyone needs to have an immune fixation to detect paraproteins, monoclonal gammopathies, and if that's the case for IgMs, everyone should be tested with anti-MAG antibodies. And this is mandatory because anti-MAG is something else, and we need to be aware that and it's treated differently, and we need to be aware that this exists and when to test it. So another important thing that happens with the new guidelines is that each of the variants, so CIDP, the distal variant that is here labeled as DAS, the Lewis-Hamner syndrome, which is the multifocal variant, etc., they all have their own specific electrodiagnostic criteria, which we don't have time to revise now, but I encourage you to look at the guidelines. So if you have a patient with CIDP that presents with distal variant, I encourage to look at the criteria and check, because they are not the same as the ones that we would use in a typical CIDP. And also, each of the variants has their own red flags and their own differential diagnosis that we need to be aware of, because we need to rule out that other things that can mimic CIDP are present. So we have to use all the tools we have available to finally decide that a patient has CIDP, because not only fulfills the clinical and electrodiagnostic criteria, but also does not have the other things that are part of the differential diagnosis. And this is important because we have this very heterogeneous disease, and we don't have biomarkers to specifically diagnose CIDP with high levels of certainty. One important thing is that some diseases that were previously considered CIDP are not considered CIDP anymore. The most, let's say, CIDP-like disease that is not CIDP anymore is probably the autoimmune nodopathies or nodoparanodopathies, which are defined by these antibodies. We will discuss a little bit more later. But also there are other disorders that can fulfill diagnostic criteria of CIDP, like MMN, that could maybe, if presented in a symmetric way, could fulfill diagnostic for motor CIDP. Anti-MAG, as I mentioned before, it can fulfill diagnostic criteria of distal CIDP, but it's something else. Or POEMS, that is there's a disease that, of course, has therapeutic implications. And the other one that has been removed from the diagnosis of CIDP, previously was included in the sensory CIDP spectrum, is CISP, or chronic inflammatory or chronic immune sensory polyradiculopathy, which now would not fulfill the criteria, electrophysiological criteria, and is considered something separate, even though it shares a lot of things with regular CIDP or sensory CIDP. So whenever we have a patient in which we think there is a possible CIDP, this is the paradigm that we need to follow. So first, assess the type of disturbance that the patient has, the pattern of weakness, if it is symmetrical, proximal and distal, or only distal, or if it is asymmetrical, or if it's there's no sensory involvement or no motor involvement. Once we have this, and if the patient fulfills the clinical criteria that are described for each of these variants, then we need to consider the red flags, the things that might lead us to misdiagnosis, and order the tests that are necessary to rule out these other red flags. If there is no alternative diagnosis that may be suggestive, then we move on to the nerve conduction studies to see if the patient fulfills or not the criteria. If the patient fulfills CIDP criteria that is completely definite, let's say, we wouldn't need to do any other test. It's not mandatory. I recommend always to have some supportive tests, because it's also reassuring to some extent to the electrophysiological criteria. But it wouldn't be necessary, let's say. If the patient does not fulfill criteria for CIDP, for definite CIDP, then and then it's possible CIDP, then we need to use the supportive criteria to upgrade, because the objective is always to try to reach the maximum diagnostic certainty, because that's where misdiagnosis is much less probable. So, and for that, we need to use the supportive criteria. One important thing is that one of the supportive criteria is response to treatment that I didn't mention before. And response to treatment needs to be evaluated objectively. It doesn't matter if the patient feels subjective improvement, which can happen a lot with immunoglobulins, for example. We need to also find the signs for objective improvement, and we are going to discuss a little bit later about it. And then, if the patient fulfills the criteria and even the supportive criteria, but there are any special features that may lead us to think that the patient can have an autoimmune nodopathy, like, for example, prominent tremor, which would make us think in neuropathy 155, nephrotic syndrome, for example, in contacting 1, very severe neuropathic pain, or very severe disease with even respiratory failure, then maybe Casper or pan-neurofasting need to be considered. And so if they are positive for these antibodies, then this is not a CIDP anymore, even if it fulfills everything else, but it's an autoimmune nodopathy, which has some therapeutic implications that are out of the scope of today's talk. So, and of course, we need to do well the diagnostic part, because we need to treat the patient correctly, and misdiagnosis would mean not to treat the patient correctly. If it is a CIDP and we are not diagnosing as such, we might be using things that are not useful in CIDP. And on the contrary, if the patient has something else, like, for example, an autoimmune nodopathy or an anti-MAG neuropathy or a POEMS, and we are diagnosing as CIDP, we would be using things that are completely useless for these patients. So we are now going to the second learning objective, which is advancing in CIDP treatment and focusing a little bit more on immunoglobulins. So this is a cartoon that we built a few months ago for a review on treatments and the mechanisms of action of the treatments. And it just displays the common understanding of the CIDP pathophysiology, in which we have B and T cells, and these B cells producing, leading to plasma cells and producing immunoglobulins. These immunoglobulins and the T cells themselves can cause damage in the case of immunoglobulins through complement most of the times, not always, but many times. And the T cells themselves can be harmful. And of course, this can lead to macrophage demyelination that is not present in all the patients, but in a substantial proportion. So the main treatments, the ones that are approved, which are immunoglobulins, corticosteroids, and plasma exchange, are unspecific treatments that target several of these pathways, particularly because plasma exchange, they remove all sorts of immunoglobulin cytokines complement, and that's of course helpful. In immunoglobulins, also scavenge complement, but also inhibit and increase the recycling of they decrease the recycling of the pathogenic antibodies, and also bind to cytokines and to cells and energize them. But then, and these are unspecific treatments which we were used to use in a treatment trial and error paradigm, which is something that of course works, because we only have 3 treatments or 3 types of treatments, and these are broad spectrum treatments. But now we have therapies that are either approved, like the FcRn inhibitors, or in the path to approval, or at least in the path to investigation, like complement inhibitors or B-cell depleting agents, in which we have targeted therapies. And this means that from now on, we are going to need to profile the patients much better according to their mechanism of disease, the predominant mechanism of disease. So afterwards, we can select much better which targeted therapy is better for each patient. Well, in practical terms, how do we use the treatment in CIDP? So IVIG is the most used treatment, clearly, at least in the US and in Europe, and is usually the first choice for most patients. It's used with a loading dose as an induction treatment of 2 grams per kilogram over 2 to 5 days, usually 5 days at the beginning, and then a maintenance dose if the patient responds. So one important thing is we need to evaluate whether or not the drug works. And this can happen as soon as after the first cycle, in the first 3 weeks or 1 month after the first cycle. If the treatment works, but it's not sufficient, we may repeat this induction cycle and then maintain for a while. There are two types of protocols, usually those that just stop the immunoglobulins and see what happens, how much do they last, and according to the duration of the treatment, then they set up the maintenance dose. And then there's the paradigm of treating for a while, maybe up to 5 to 6 cycles, and then stop or start decreasing the dose progressively. This is important because some patients, as I said before, even 20 to 30% of the patients enter into remission. So we have to reevaluate the need of the treatment in these patients, and to reevaluate that every 6 to 12 months in early patients, let's say, and maybe once every 3 years or something like that in patients that have been for long. We need to reevaluate the need of the immunoglobulins. And how to do that? As I said, we can stop the immunoglobulins and see what happens, or we can decrease periodically, something that is much well tolerated by patients, decrease periodically the amount of immunoglobulins we infuse and see what happens when we are able to taper the immunoglobulins completely. The main issues of immunoglobulins is the intravenous access. You need a hospital or infusion clinics. And of course, in some older patients, this can lead to thromboembolic events. And very frequently, patients have headache. And this is something that is, it's a very good treatment, but is associated with these problems. If we keep on the induction treatment, the second thing we have, and the second most used therapy, is corticosteroids. And corticosteroids are used as an induction and as a maintenance, and usually are used in patients that, or in places where they don't have access to immunoglobulins or good access to immunoglobulins, and in those that have immunoglobulins contraindicated for whatever reason. There are different ways of doing it. With the typical paradigm was oral prednisone, 1 milligram per kilogram, 1 month, and then taper down. But now it's probably more frequent to have patients with pulsed dexamethasone that can be used orally, or pulsed intravenous methylprednisolone. And then we have to expect the first response a little bit later. It takes some more time to have the patient on corticosteroids respond to what it takes with immunoglobulins, and this has been compared head to head. And but the good thing is that sometimes, or more often, the patients with corticosteroids, the effect lasts longer than with immunoglobulins, and patients enter into remission more frequently. The corticosteroids have a lot of problems. You probably all know that. And this is something we need to consider when choosing them as a first-line treatment, particularly in elderly people, in which not only the typical side effects of, glucose metabolism problems, hypertension, osteoporosis, etc., happen, but also cognitive and behavioral problems. And finally, plasma exchange is the other induction treatment. It's not usually used as maintenance, and it's used for those patients in which they have relapses that need to be rescued rapidly, or in patients that are not responding to the other two induction treatments. Is relatively safe, but it has also the inconvenience of needing a hospital and a full setup that is not always present in everywhere. And then we have subcutaneous immunoglobulins, which are not used for induction. They are not approved for induction. They are approved for maintenance. So this is patients that have responded before to intravenous immunoglobulins and maybe fluctuate a lot or have some systemic symptoms of the infusion. And then we can use subcutaneous immunoglobulins to decrease this. The regular subcutaneous immunoglobulins are used at a dose of 0.4 grams per kilogram, but much more often in a conversion 1-to-1 with the intravenous immunoglobulin schedule that the patient had. And in this case, the dose is calculated per week. And the administration frequency, of course, depends on the amount of immunoglobulins. Usually, it's needed twice a week in patients with very high doses, maybe 3 times a week, but that's not so common. And same as it happens with intravenous immunoglobulins, we need to reevaluate the need of immunoglobulins periodically to see if the patient has entered into remission and maybe does not need them anymore. They have much less systemic effects of intravenous immunoglobulins, but sometimes they are also perceived as problematic when local injection reactions appear, or when maybe the effect is not perceived as strong as sometimes happens with intravenous immunoglobulins. So the challenges, I mentioned them already with IVIG, is the risk of thromboembolic events, the cost and the access, which needs hospital or infusion clinics. In the subcutaneous immunoglobulins requires training of the patient or the caregiver, and then it also the fact that they are not supervised every time they are receiving the immunoglobulins maybe leads to lower adherence or compliance with the treatment. Corticosteroids have all the effects that you probably know, and they are tolerated poorly, particularly for long term and in elderly people. And then plasma exchange has the problem of the need of specialized equipment and personnel, and it's pretty labor intensive when it's decided to use. With that, this is the evidence that supports the use of immunoglobulins. So as I said before, intravenous or subcutaneous immunoglobulins. Intravenous immunoglobulins are a very good choice, but there are patients that are subject to either systemic side effects or to fluctuations, which are really common in immunoglobulin responders. So to overcome those two things, subcutaneous immunoglobulins are also as an option. And the first ones were regular subcutaneous immunoglobulins, not facilitated immunoglobulins. And this is the PATH trial, which is the pivotal trial that described the utility of subcutaneous immunoglobulins. They compared two doses of subcutaneous immunoglobulins at 20% dose, 0.2 and 0.0 grams per kilogram. And both doses were better than placebo, although both of them were associated with a few more relapses than would have been expected in these cases that were supposed to be all of them in the immunoglobulin responders. This happened probably due to different reasons, but one of them is that the dose was not tailored to the previous dose of the patient. So they were assigned randomly to 0.2 or 0.4, but the patient may have needed much higher doses when they were under intravenous regimens. The primary endpoint was, as always, a point increase in adjusted INCAT, and this is what we are seeing here: the probability of the primary outcome to happen, which was the worsening in 1 point of INCAT. And then there were several other outcomes that were all of them positive and differential between the placebo and the treated arms. But now, so one of the problems of these subcutaneous immunoglobulins, or one at least thing that can be improved, is that they need repeated doses, usually, as I said, 1, 2, or even 3 infusions per week, depending on the amount of grams that we are using. And with that in mind, now we have facilitated immunoglobulins, facilitated subcutaneous immunoglobulins, in which we have the subcutaneous immunoglobulins, which are 10% now, plus hyaluronidase, which cleaves the hyaluronan or the hyaluronic acid, and this cleavage facilitates the dispersion of the full volume that is infused subcutaneously in a much wider area, which allows for much higher volumes to be infused at once, and also it's much easier to infuse the subcutaneous immunoglobulins. This initially looked as difficult to let's say to sell to patients or to convince patients to use this, because they had to sometimes have maybe 400, 600 milliliters of immunoglobulins all at once subcutaneously, which was conceived as maybe impossible. But in truth, what happens is that patients tolerate it pretty well. And after one couple of days, the immunoglobulins diffuse pretty well, and the patient is not does not have a bump in the belly anymore. And this was described in the advanced trial, which was also positive, clearly positive, with a relapse rate in the placebo arm that was clearly higher than in the patients using the facilitated immunoglobulin, subcutaneous immunoglobulin, and this effect lasting very long. You see that the study, the long-term extension, took almost 350 weeks, and the annualized relapse rate was 4.5% in those patients that kept on the trial, associated with mild transient, usually side effects, as with regular subcutaneous immunoglobulins. But we have novel things. Some of them are already here, like FcRn inhibitors. You probably have already used efgartigimod for maybe myasthenia, but also for CIDP. So very briefly, FcRn is a receptor that is in charge of recycling immunoglobulins. And with this receptor is blocked, the immunoglobulins are targeted to the lysosome and degraded. So the biological effect is that inhibition of FcRn leads to a decrease in immunoglobulin levels of all types of immunoglobulin, IgG immunoglobulins, but all types of immunoglobulins, good ones and pathogenic ones. And but this results in improvement of antibody-mediated disorders. And with the idea that CIDP has, at least some patients of CIDP have an IgG-mediated mechanism that is predominant, this this mechanism was assessed in CIDP. There are several trials ongoing, but the one from which we have results and that has led to the approval of efgartigimod in the US and in Europe as well is this trial, which is the ADHERE trial. It has two phases: an open-label phase in which patients that were forced to worsen, to relapse, were rescued with efgartigimod, and 2/3 to 70% of the patients responded, improved after efgartigimod. Those that didn't improve were removed from the trial, and those that were improved were randomized to either placebo or efgartigimod. And there was, again, a clear difference with a relative risk reduction of 61% between efgartigimod and placebo, and this led to the approval of the drug. On top of FcRn inhibitors that have, as I said before, been approved already, we have things that have not been approved yet. This is off-label or investigational, let's say more accurately, but they are showing also promising results. Complement inhibitors we are used to C5 complement inhibitors, which are being used in myasthenia gravis and in other disorders, but we are now talking about inhibitors higher up in the cascade. In this case, the one that is more developed in clinical trials is riliprubart, which is targeting C1s, activated C1s. But there are other complement inhibitors that will come in the future that are being used, for example, in multifocal motor neuropathy, that are targeting C2, for example, and they selectively block these complement factors. The blocking up here has two advantages. First, in terms of efficacy, it blocks not only the membrane attack complex, but also all the collateral actions of the complement in terms of opsonization, of chemotaxis, of signaling to the macrophages. And also, the other good thing of targeting up here is that it leaves intact the lectin and alternative pathways, which are also important for membrane, for bacteria protection. And riliprubart, which is the one that I said is more advanced in development, has been tested in an open-label trial, phase 2, which is the one we have results from. And now there are two phase 3 trials that are awaiting publication because they are already ongoing. So in this trial, it was open label, but the good thing is that it's a trial that was aimed to treat patients treated with a standard of care, refractory to the standard of care, or naive. The primary endpoint in the standard of care treated was to remain stable because they were on immunoglobulins or corticosteroids. They were put on riliprubart and then removed remove the immunoglobulins and then put on riliprubart. And the objective was to see if they were stable. And this happened in 87% of the patients, which is a very good number. But on top of this stability, 52% of the patients that were supposed to be treated well with their standard of care, they improved further. So this was somewhat unexpected, but this happened, and this was taken as an additional proof that the drug was working. The other thing was that in SOC refractory, which is a more challenging population because they are not improving with the standard of care, 50% of the patients improved, and 75% of the naive patients improved as well. So it demonstrated let's say, reached the primary endpoints in all three subgroups. But the criticism here is this is an open label, and maybe there's a lot of placebo effect, which in fact there might be. But they also used a neurofilament light chain as an objective biomarker for axonal damage, and all three arms had a significant reduction of around 30% of the neurofilament levels compared to baseline, which provided an objective marker beyond the subjective or the partly subjective outcomes that were assessed clinically. And all these two pieces of information suggest that this can be a good treatment in the future, and this is what it's being now assessed in two clinical trials. And finally, some messages regarding the collaborative strategies for diagnosing and managing and monitoring CIDP. So one important thing is that this is a neurology-centered disease, but it needs a multi-tiered approach in which we need to combine different aspects of the disease and particularly different sources of information, including patient-reported outcomes, which are very important, and we will discuss later a bit. So the second thing is we need to use the tools appropriately and not rely only on subjective perception of the patients to assess progression and response. And then we also have to listen to our colleagues. Sometimes we have a patient in the infusion clinics and it's been there forever, but the nurses are the first ones in noticing that the patient maybe is not walking as well as the patient should or was used to walk. Maybe the ones that are detecting the side effects, etc. So we need to listen also carefully to our colleagues that are also taking care of these patients. And of course, in particular, in those patients that are receiving treatment at home, we need to be very we need to listen carefully also to the caregivers and the patients themselves to see whether or not the drug is doing what it's supposed to do or some side effects are happening. Very importantly, and this I mentioned this briefly before, in the diagnostic part, we need to use validated scales for monitoring disease progress. And also in monitoring response to treatment that is going to be used in the diagnostic process, in the response to treatment supportive criteria. INCAT is the most widely used. I would say it's easy. It's very, it takes 30 seconds to score, and it measures arm and leg disability. Then we have patient-reported outcomes that are very useful as well because they are self-administered, and you can tell the patient to self-administer, periodically, maybe every 3 months or whatever. And this is a validated way of capturing some changes. I recommend always to have some, let's say, impairment assessment and disability assessment, and we can use INCAT and RODS, for example, in the disability side, but use, for example, grip strength or time up and go or MRC sum score as the, let's say, impairment part. but the combination of two is much better than using just one. We can also capture quality of life measures, which are much less precise in terms of the disease-specific changes, but are important to kind of feel how the patient is doing. And then, as we don't have also very good biomarkers to assess the disease, this is why prompts matter. Finally, regarding how we decide how to choose a treatment and or the therapeutic process in general, we need to take in account not only what we think it's going to be good, but also what is the context that is happening, and do shared decision making, because maybe we can choose a subcutaneous immunoglobulin, but maybe the caregiver is not, he cannot do this, or maybe the patient cannot do this him or herself. Also, we need to take in account not only efficacy measurements, but also the safety preferences, or safety, let's say, tolerability preferences. We need to have in mind the comorbidities, the age, for example, the functional status, working status. For some patients that are still working, it's very important to be autonomous, and maybe in those cases, subcutaneous is better. Then we need to, so in summary, we need to align with patient preferences and lifestyle, because that's also important, also to adherence. And finally, we have, of course, to take into account cost, availability, and insurance, because that's all, of course, something important to select the treatment. An important thing that we need to take in account is, of course, management of CIDP is patient-centered. And this means that all the team, the collaborative team, has to join the efforts and synergies to help the patients. Of course, the neurologist probably is the leading physician in this task, because it's, of course, the expert, and it's the one that centers all the attention for the patient. But there are many other professionals, nurses, physiatrists, physical therapy, rehabilitation, etc., that are really important also in the management of these patients. And of course, another important figure that we need to take into account are patients' associations and advocates. For example, globally, the GBS CIDP Foundation, or in Europe, for example, EPODIN, these are resources for the patients that are really helpful, because they have lived the experience in their own persons, and this for patients helps find someone that understands, having gone through this same experience, the full meaning of what it means to have CIDP. So always consider that this is an effort that takes, of course, professionals, but not only professionals, also patient associations, caregivers and families, and of course the patient in the center. We've learned a few things, and now we have to put this education into action. And I recommend that we maybe follow these SMART goals, this SMART paradigm. So let's try to apply this in a practical way, being specific. So, for example, developing a protocol or a pathway in the hospital that embeds the guidelines, the formal recommendations, the evidence-based recommendations, that are measurable, that we are able to demonstrate that what we are doing in a quantifiable way is changing the disease, if it's in disease outcome, but also if it's in disease, let's say, proportion of patients misdiagnosed, etc. Try to implement a measurable KPI, for example, something that needs to be achievable. So, for example, one of the objectives we might think ourselves is have most of the patients stable or improved. Not all of them, because it's impossible. Not perfect all of them, because it's impossible. So it needs to be achievable. But with that in mind, we can, let's say, get into action. Of course, we need to be relevant. We are trying to improve the quality of life of the patients, and this needs to be always the core of our questions. And finally, we need to be, if we are taking care of these patients, we need to implement this as soon as possible, and maybe commit to a specific deadline, because otherwise this, let's say, evidence-based protocols and guidelines may not be implemented ever. And I recommend that you follow, let's say, a systematic approach with them. And with that, maybe we can take some questions from the audience. So let's start with the first question. So in rural or resource-limited settings where patients may live far from infusion centers, what strategies can be used to emphasize patient autonomy and shared decision-making? And what are some ways to support patients in monitoring their symptoms between visits? Well, so that's an important question, particularly for the US, but also in Europe. There are several ways to address that. So, for example, the first thing is that in some places, in Europe at least, but I think it might happen also in the US, there are home infusions. This means that it's not the patient that is going to the infusion centers, but there's some nurse that is in the surroundings and that is able to administer the drug or the treatment without having the patient travel many kilometers for this purpose. A second option would be to select maybe a drug that is used orally or that is self-infused, like for example, corticosteroids or subcutaneous immunoglobulins, or even now efgartigimod. And in that sense, the treatment can be administered at home, but we would still have the problem of how do we monitor the patient without having the patient come to our visits, and which might mean a lot of burden for them. And I think this can be overcome by using some sort of remote scoring system, and there are several that can be used. For example, the ROTS. It's a very good patient-reported outcome that can help monitor disease activity while the patient is being infused or is taking the drug at home. And the other option is, for example, the use of grip strength. Maybe provide the patient with a vigorimeter and have the patient self-assess while taking the drugs at home. This, in fact, there's some studies regarding home monitoring, and for example, Jeff Allen has this study, the Gripper study, in which the patients monitor themselves at home very frequently, and that was really successful. And for example, in some clinical trials, that happens every day in some, let's say, moments in which they need to intensify the monitoring. So there are several ways to do this shared monitoring and not have the patient travel too far away from their rural setting. Second question here. Is there a difference in how subcutaneous immunoglobulins and facilitated subcutaneous immunoglobulins are used in Europe compared with here in the US, especially when patients transition from IVIG? Do clinicians there approach the process differently, and what lessons can we learn? So I don't think that it's different. I think the protocols are very clear for both of subcutaneous immunoglobulin formulations. What maybe happens is the amount of the use of each of the immunoglobulins varies a lot. I wouldn't say across US or you comparing US and Europe, but even across Europe, it depends a lot. So, for example, in some Northern European countries, like the Netherlands, for example, they have home infusions, IV home infusions. It's something that the patients value a lot, and if they administer themselves at home, they are not receiving the visit of a nurse, which it's also providing some care beyond the immunoglobulins themselves. So this feature of the system makes less suitable the Netherlands for the use of subcutaneous immunoglobulins. On the contrary, in Spain, it's much wider, it's much larger in size. We have more rural areas. The infusion clinics might be not so close to the patient, and we don't have home infusions, IV infusions, and this means that it's a more suitable country for using subcutaneous formulations. But the variability depends a lot on the system and the features of the country. The third one, in your clinical practice in Europe, what role do infusion nurses and caregivers play in monitoring treatment effect? And how do you integrate their feedback into treatment decisions? This is a very important question. So we are a reference center in Spain for these neuropathies. And by being a reference center, we are forced to have what we call advanced practice nurse, which is a nurse that is a specialist in this type of neuropathies. Of course, this nurse does other things. It's not only doing this; it's doing other neuromuscular things like taking care of myasthenia, of ALS patients as well. But it's someone that is highly trained for training patients in the use of immunoglobulins, training patients to self-administer some scales and some, grips, etc., and that is trained to monitor side effects, for example, or being aware of which complications or issues may be decreasing the adherence of the patient. And so having this nurse and these, let's say, colleagues that are specialized in the disease but are not necessarily physicians and that are in much closer contact with the patient, and also that have a phone number, for example, that they can reply if the patient has some problems, that's also very, very important. So whenever possible, having someone trained, it's very, very useful for the management of the patient, and also to save us work in the end, because they do a lot of what's needed to have the patient perfectly followed up and monitored. So thank you very much, everyone. It was a pleasure to have this lecture with you. And if you anyway have any other question, I would be happy to answer it by email or any other means